Hello everybody. This is my case presentation of a muga scan that I did while I was in my cardiac rotation. My patient is a 59-year-old male. He had a heart attack in late 2019 and a history of high cholesterol that he was being treated with medication for. He went in for a echocardiogram and a nuclear stress test earlier in the year in about February, and both of those tests had conflicting results when it came to ejection fraction. Now, the echocardiogram came out with a ejection fraction of 52%, and the nuclear stress test came out with the result of 38%. So that was quite a difference, and that's why they ordered the muga scan to figure out what the actual ejection fraction was for his heart. So this is the splash view of the stress test results, the top row being the stress and the bottom being the rest. Each frame is numbered so that they're matching up so that you can compare the stress and the rest of each slice. There are three different axes being shown on these results, and that leads to my first question. What are those three axes? I'll give you a moment to think about it. If you guessed the first view being the short axis, you would be correct, and it is followed by the vertical long axis and the horizontal long axis. When observing these slices, you can see that the inferior lateral portion of the left ventricle has significant lack of perfusion. This is another view of the stress test results, and it's focused on the apex as you're looking at the heart from the apex going towards the base. You see a bluish purple spot in the middle of the apex on those images on the stress perfusion and the rest perfusion. It is on both of them, so you'd call that a fixed or matching defect. That really just brings me to my second question. What does a matching defect represent? And then what about a non-matching defect? Now, a matching defect is going to reflect like an infarct or a heart attack, meaning that even during stress, you're not getting any type of blood flow or perfusion, and pretty much just means dead tissue. Now, if it is a reversible or a non-matching defect, it's going to really represent ischemia, and that would be if the defect is seen on stress but not on rest. And you can see on the bottom of this image and all of the following images, as we see the different views, the reversibility perfusion. The parts that are lit up are the areas that have reversible or a non-matching defect, pretty much. This is the septal view of the stress test results. Just like the previous slide, it's got the stress perfusion percentage, rest perfusion percentage, and reversibility perfusion. One thing I wanted to point out is on the bottom right of these scores, you can see that circle divided up. That is the polar map scores. They are divided into 17 sections that all coincide to a different part of the heart. So the real things that light up are the inferolateral wall that has scores of 2, 3, and 4, and the inferior wall that has scores of 1 and 3. The scores indicate how well the perfusion or how impaired the perfusion is. So like a score of 0 would be normal perfusion. Score of 1 or 2 would be pretty normal perfusion, just a mild or moderate impairment. 3 is going to indicate a significant amount of impairment in perfusion, and 4 would be no perfusion at all. So based on that, you see that in the rest and stress, you are seeing some of the different scores. Now, these scores can be summed up for the items on the screen labeled SSS, SRS, and SDS. SSS would be the summed stress score, so that's a combination of the scores on the stress test, and then the SRS is going to be the sum scores of the resting part of the test. The SDS is going to be the sum difference score. So you subtract the scores, and then for this specific patient, you have a SDS of 7. That would indicate that there is a significant amount of reduced blood flow to that heart in the specific areas of the inferior and lateral walls. This is the lateral wall representation of the left ventricle perfusion. You can see that there is some reversible areas in the defects, as you can also tell by comparing the polar maps. In the stress area, you're seeing a lot of defects in the lateral inferior portion of the lateral wall, but in the rest, you're only seeing a minor defect. You're only seeing one score of 2 instead of 2, 3, and 4. So most of that is pretty reversible. It's not the same, so it's not necessarily fixed as much as the inferior wall would be. On the stress and rest perfusion, where it shows the heart and the base, lateral, anterior portions, and the apex, you can definitely see a lack of perfusion there. And on this representation of the inferior wall, you can see the major defect on lack of perfusion, and the scores on the rest and stress polar map are the same on each rest and stress, meaning this is a fixed defect. But you can see very clearly it is a pretty massive defect on that inferior wall of the heart. And on this this picture shows the volume of the heart when it's in end systole. So when it's completely contracted and the blood is pushed out into the atrium. The green outline around the heart is going to be the end diastole. So that's going to show the difference between that green line and where you're seeing the perfusion is going to be the difference between the systole and diastole, which is going to be, those volumes are going to be used to calculate the ejection fraction. As you can see on the right-hand side under the volume and the EDV, ESV, which are the end systolic and diastolic volumes, the ejection fraction is 38% on this stress image. As I said earlier, the echocardiogram results were 52%, and that's why we ordered the muga scan. Now that we have gone over the stress test results, now we can get into the muga information. The indications for a muga scan include the assessment of ventricular function, including ejection fraction, wall motion, ventricular volume, cardiac output, and systolic or diastolic function. It also is indicated for detection of location and extent of coronary artery disease, determination of ischemic versus non-ischemic causes of congestive heart failure, monitoring of potential effects of cardiotoxic chemotherapy agents, and evaluation of valvular abnormalities. It is also the gold standard of ejection fraction. My next question is, what is generally considered a normal ejection fraction? A normal ejection fraction is going to be anywhere between 50 and 70%. And the ejection fraction, just as a reminder, is a comparison between the amount of blood pumped out of the ventricle and the amount that is in the chamber. So anything but like 41 to 49% is moderate. Anything under 40% is going to be a very reduced ejection fraction. As for patient prep for the muga procedure, there is not too much patient prep at all. The patient should be made aware of what the scan entails, and then they should be prepared for getting an IV. Now, the patient may eat or take medications as necessary before the procedure, and a history should be taken, including indication for testing, symptoms, medications that they're currently on, any previous cardiac procedures and results. A physical exam, any history from that should be taken, as well as any previous nuclear medicine studies. My next few questions are: what is the radiopharmaceutical used for this study? What's the half-life? And what is the critical organ? I'll give you a few seconds to think about that. All right. So the radiopharmaceutical is going to be technetium-99 tagged red blood cells. The half-life is going to be 6 hours for that tech. And the critical organ is going to be the spleen. My next few questions are: what is the radiopharmaceutical? The dose for the labeled red blood cells is going to be between 20 and 25 millicuries. The camera type that is going to be used is going to be a small field of view, although you can use a large field of view camera if needed. My facility used a Digirad upright solid-state SPECT camera, as pictured in the slide. And the energy peak is going to be 140 keV with a window of 10%. The views acquired for this are going to be the anterior, the left lateral, and the LAO. The LAO is really important because it's looking for the best septal separation between left and right ventricles, so you can get that ejection fraction, and that may require adjusting the patient's position on the seat in order to get the best possible view of that separation. The counts acquired are going to be between 200,000 and 250,000 counts per frame, and we did it based on time at my facility, so we would do 5 to 10 minute pictures per view. So in order to do the procedure, you are going to have to tag red blood cells with Tech99. Now you use an UltraTag kit in order to do so, and that contains 3 different things. It contains a reaction vial, which contains stannous chloride. It's got syringe 1 that has sodium hypochlorite, and syringe 2 that has citric acid. So first you would withdraw blood from the patient in order to tag it. Now that brings me to my 5th question, which is: what size catheter or what size IV needle would you want to use to collect blood for tagging, and why? I'll give you a second to think about it. So the answer would be anywhere between 18 and 21 gauge needle, as to avoid hemolysis, which means breaking of blood cells. Because if you use anything smaller than a 21 gauge needle, the red blood cells are going to become damaged. And if they are damaged, once you tag them, they will just pretty much light up the spleen. You're not going to get as much uptake in the heart because the damaged blood cells will go straight to the spleen. So I withdrew 3 cc's of blood from my patient. I added it into a tube of heparin that we already had. You can use heparin or ACD as an anticoagulant. Then I added the blood to the reaction vial, and then I gently inverted it about 3 or 4 times, and then I allowed it to react for 5 minutes. Then I added the contents of syringe 1, gently inverted it 3 to 4 times, and then I added the contents of syringe 2 and did the same thing. Once that was all added, I made sure to take some air out of the vial, the reaction vial, because as you're adding more things, the air is not escaping. So if you don't want blood to squirt out all over you, I do suggest taking air out of it as you're adding things into it. I placed it back into the lead shield with the cap, and then I added my tech. Once I added my tech, I inverted it about 3 or 4 times just to allow it to mix. And then you allow it to react for about 20 minutes. Every 5 minutes I would go back and invert it just to make sure it was mixing occasionally. Now I wanted to make sure that I was getting it after that 20 minutes, so I would set a timer for myself. And then you re-inject the tagged blood back into the patient. You really don't want to wait more than 30 minutes from taking the blood out of the patient to getting it tagged and re-injecting it, as to ensure that there's no red blood cell damage or anything like that. After re-injecting my patient with the tagged red blood cells, I would start taking my pictures. I would make sure to go ahead and put the leads on them because this is a gated study, and then we would take the 3 different views. My clinical site always started with the LAO view first in order to ensure that we got good septal separation between the ventricles. And then we would move on from there. Once we knew that we had a good LAO image, then we would move on to the left lateral and the anterior view. Once I obtained those views, I would go ahead and use the LAO view to calculate the left ventricular ejection fraction, the end diastolic volume, and the end systole volume. I would then review the cine images for all of my views, looking for rhythm disturbance and wall motion abnormalities, and then review the automatically drawn region of interest over the left ventricle and adjust if necessary. So these are the 3 views that I was talking about. On the top left, you have the LAO view. You have a good septal separation between the left and right ventricle there. Next to that, you have the left lateral view, and on the bottom, you have the anterior view. Normally, if you were pulling this up in the processing, it would be a cine image, so it would be moving and you would be able to see the ventricles contracting and filling, although we were having troubles getting that information as a cine, so I just have the pictures for it, but you can imagine. You would be reviewing these cine images in order to look for any wall motion abnormalities or anything like that that you could report. So these are the 3. This shows the results for the left ventricle function. It provides on the bottom left, it provides the LAO image with the region of interest that is automatic. On this one, it showed up automatically fine. We didn't really need to adjust anything on there. It's perfectly surrounding the left ventricle. On the right, you see the left ventricle activity curve, and that's going to show the peak ejection rate and the peak filling rate for the left ventricle. And then you can find that information above the picture of the LAO, and it shows you the actual volume per second that's being ejected or filled. It shows the heart rate, the end diastolic volume, the end systolic volume, and of course the ejection fraction. The ejection fraction is 38% on the muga, which matches with the stress test. So there must have been some kind of technical issue when it came to recording the ejection fraction for the echocardiogram. The only possible complication that we had while getting this muga scan was just patient movement. My patient just was very anxious to get out of the department. It was the end of the day. Mugas are usually the last thing that we have scheduled as order to, make sure that we don't have multiple bloods being tagged during the middle of the day and no confusion, so we can make sure that there's no possible mistakes when it comes to giving or taking and tagging and giving back blood. Now, we were taking the LAO view, and then he was just very shifty and anxious, so I had to literally stop the view and then let him know, hey, these are 5-minute pictures each time. It is very important for us not to have movement so we can get the best possible results. If you continue to move, we're going to have to keep retaking them, and it's going to be longer for you to be in the department. He seemed to understand that and then was fine the rest of the time. We just had to retake that LAO view. Other possible complications that can occur while doing this scan are improper tagging of red blood cells. Like, let's say you put in syringe 2 instead of syringe 1. That can definitely cause improper tagging. Damaged red blood cells during blood draw. Like we talked about, you have to have a larger bore needle in order to remove the blood cells without damaging them. Improper angling of the patient, causing no separation of ventricles. That would be a bit of an issue when it came to getting and calculating that ejection fraction. And then also, if the automatic drawn ROI is not accurate, let's say it's covering both the left and right ventricle, you would then not have the right information and the ejection fraction would be not correct. So you want to make sure that that's drawn correctly. And if it's not, you want to redraw it in order for it to be correct. Something that could improve this scan would be using SPECT acquisition for the muga. That way you can get more information about wall abnormalities or give more information about not only left ventricle ejection fraction, but right ventricle ejection fraction as well. Although the left ventricle ejection fraction is really what we were concerned about because those other 2 previous tests that were given that had different results. And these are my references. Once again, thank you for sitting through my case presentation. If you have any additional questions, please do comment them and I will get back to you. Thank you.